Good morning. My name is Shalini Mustala, and I am a research associate with the Public Policy Institute of California. Welcome to our virtual program featuring the findings from PPIC's latest report, Health Conditions and Healthcare Among California's Undocumented Immigrants. The report, technical appendices, and policy brief, as well as the slides from today's presentation, are all available on our website at ppic.org. For today's program, I'll walk you through some of the key findings of the report. And then I'll turn it over to my colleague and lead author, Paulette Cha, who will moderate today's panel conversation before opening it up to questions from the audience for the final 15 minutes of the program. This research and event are supported with the funding from California Community Foundation. We'd like to thank them for their support. As a reminder, PPIC is a public charity and does not take or support positions on any ballot measure or legislation, nor does it support, endorse, or oppose any political parties or candidates for public office. And lastly, if you have a question for our panelists or about the report, please send it to the email address shown on the screen, ppiceventsquestions@gmail.com. Please include your name and organization with your email. And with that, let's start the presentation. As you can see at the start of this timeline, the Affordable Care Act expanded Medi-Cal to all low-income Californians with restrictions based on immigration status. Since then, California has been expanding Medi-Cal eligibility to low-income undocumented residents in a phased manner. Medi-Cal expanded its unrestricted coverage to undocumented children in 2016, young adults in 2020, and older adults in 2022. In January 2024, the program becomes available to all ages, regardless of immigration status. And the state can expect an influx of new Medi-Cal applicants. Information on the health of undocumented immigrants and the health services they use can help the state plan for the needs and costs of this final expansion. Community health centers are networks of clinics that are an important access point for low-income Californians, including many undocumented immigrants. We studied clinic visits of low-income, likely undocumented immigrants who qualify for Medi-Cal, except for their immigration status, comparing them to Medi-Cal patients in the same clinics. We studied about 370,000 adults who made over 5.4 million visits to 350 community health centers in the state. We use electronic health records between January 2018 and November 2022 to study several outcomes, including the types of visits patients make for healthcare. Preventive and behavioral health are key outcomes because they are fundamental components of healthcare that low-income uninsured individuals might miss due to cost or other barriers. We also conducted a case study of Los Angeles County, which has the largest population of undocumented immigrants among California's counties. This includes a separate quantitative analysis for LA County, along with in-depth expert interviews to incorporate qualitative insights. Looking at preventive care coded visits like annual health checkups, undocumented patients are less likely than Medi-Cal patients to visit a community health center specifically for preventive care. Statewide, visits by undocumented patients are 20% less likely to be coded as preventive care, as shown by the orange bar in the figure. Undocumented immigrants are less likely to have a preventive care coded visit, and this difference is consistent and statistically significant among all age groups, both statewide and in LA County. We explored whether undocumented immigrants receive age-appropriate preventive services like cancer screenings. Early detection is vital for breast and colon cancer, and screening is recommended for both. Statewide and in LA County, being undocumented had no significant association with getting mammograms or colonoscopies, as shown by the squares in the table with no colored fill. However, in LA County, undocumented patients were 21% more likely to undergo stool colon cancer tests. Similar to the stool test in LA County, undocumented patients were 23% more likely to receive vaccination for shingles. Unlike other screenings, stool tests and shingles vaccinations can be done at community health centers without a referral. The behavioral health visits in the clinic's data includes visits for mental health and or substance use disorder, with most visits being for mental health services. From our analysis, we found that statewide, being undocumented increases the likelihood of behavioral health visit by 37% when compared to the Medi-Cal group. This is shown by the orange bar on the chart. Looking separately at the Los Angeles County, this likelihood is even higher at 47%. Statewide, the association with undocumented status in using behavioral health services is concentrated in undocumented immigrants who are 26 and older, as shown by the two solid bars in orange. In this chart, bars with solid fill represent significant results, and the bar with an outline but no solid fill represent results that are not statistically significant. In LA County, the association with undocumented status is present in all age groups, but is especially high at 70% among young adults, as shown by the third bar in dark blue. Several experts in our interviews shared insights supporting the high demand for counseling services. They report that undocumented immigrants need and use more behavioral health services because they have more trauma compared to the Medi-Cal comparison group. The interviewees noted that many undocumented immigrants are managing trauma, including trauma related to migration, domestic violence, or experiencing war in their home countries. These interviewees highlight a strong demand for behavioral health despite challenges in finding bilingual providers for counseling. Long wait times for appointments also pose challenges to accessing behavioral health services. One interviewee offered an example of how fireworks on July 4th can trigger trauma for undocumented immigrants coming from war-torn countries. Experts in Los Angeles highlighted barriers to healthcare access faced by undocumented residents. According to every expert we interviewed, the federal public charge rule is a key barrier to accessing healthcare and other safety net resources among undocumented immigrants. The interviewees also highlighted that lack of knowledge about the complex health system and safety net programs can lead people to forego benefits. The high cost of living in LA County, lack of transportation, and language needs among undocumented immigrants also pose barriers to healthcare. Recent Medi-Cal expansions for undocumented immigrants show different responses among those who are newly eligible. The Medi-Cal expansion in 2020 targeted young adults up to 26, and the expansion in 2022 targeted older adults over 50. We saw that older adults who became newly eligible visited clinics more often than younger adults. The final Medi-Cal expansion, targeting ages 26 to 49, is expected to yield similar patterns, with older adults potentially displaying more interest in enrollment. County welfare departments, community health centers, and immigrant-serving organizations should prepare for an influx of Medi-Cal applicants and anticipate higher demand for behavioral health services. Providing accurate information about the program, enrollment assistance, and language services can ease barriers to care and help prepare for the upcoming Medi-Cal expansion. Clinics would benefit from resources to hire more staff, especially bi- or multilingual staff. Expanding telehealth use may ease some barriers to care, like transportation challenges, difficulty scheduling visits around work, and concerns about being exposed to immigration enforcement. To facilitate telehealth adoption, providing tutorials and hands-on assistance through trusted nonprofit organizations can make patients more comfortable with the technology. We analyzed telehealth visits for the study population and have a set of findings related to their telehealth use in the project report. All right, that concludes the presentation. And if you have a question for our panelists or about the report, please send it to the email address on the screen, ppiceventquestions@gmail.com. Please include your name and organization with your question. With that, I'd now like to welcome my colleague Paulette Cha to moderate today's panel discussion. The panelists will share insights and lessons learned from the past 3 Medi-Cal expansions and discuss the unique challenges and priorities for the upcoming Medi-Cal expansion that extends eligibility to all low-income undocumented immigrants.
Thank you, Ms. Mustala. That was fantastic. I will now introduce today's distinguished panelists. Their bios are on the PPIC event page, so I will give just brief introductions. First, Rashina Duree is Deputy Director of Self-Sufficiency at the County Welfare Directors Association, or CWDA. Ms. Duree is the policy lead for a portfolio that includes Medi-Cal, CalFresh, and CalWorks. Ms. Duree previously served with the California State Association of Counties, the State Department of Social Services, and with the Sacramento County Department of Human Assistance. Ms. Duree has a Bachelor of Arts in Sociology from California State University, Sacramento. Welcome. Our second panelist is John Heitzman. Dr. Heitzman is Associate Professor of Family Medicine at the Oregon Health and Science University, where he co-directs the Primer, or Primary Care Equity and Latinos Center. Dr. Heitzman is a family physician practicing in a community health center in Oregon with a passion for delivering quality primary care to all people, and is a researcher of health disparities among racial and ethnic minorities. Dr. Heitzman is an affiliate investigator with the nonprofit OCHIN and a co-author of the report presented today. He received his MD from Temple University and holds master's degrees in public health and in clinical research. Welcome, Dr. Heitzman.
Thank you.
Our third panelist is Richard Pan, who is a member of the state's Healthcare Affordability Board. Dr. Pan is a volunteer pediatrician at the Sacramento County Health Center, a researcher, and a former senator and assembly member. In the legislature, he chaired the Assembly and Senate Health Committees and AAPI Legislative Caucus. Previously, he was a professor at UC Davis, where he was Pediatric Residency Program Director. Dr. Pan received an MD from the University of Pittsburgh and an MPH from Harvard. Welcome, Dr. Pan.
Thank you.
Thank you all for joining us. So let's begin our conversation. So as we all know, January 2024 will bring the state's 4th and final Medi-Cal expansion to undocumented residents. What have we learned from implementing the last 3 expansions? And do you foresee challenges specific to this 26 to 49-year-old age group? Ms. Duree, can you start us off?
Thanks, Paulette, for the question. But I wanted to start off by saying we're really excited about this additional phase of including the adults in healthcare medical coverage. It's obviously been a gap with the previous expansion, so going through this process is really exciting for counties and should be really exciting for the state of California. But as you identified, we've gone through this process of these massive expansions really recently, including the undocumented population. So we're in a great spot to identify lessons learned through those expansions. And I think one of the areas that really is top of mind for counties are those partnerships with external partners, those CBOs, when you're dealing with a community that may not have had a lot of interaction with counties or with a lot of interaction with government entities, even when it comes to public benefits, having trusted messengers out giving adequate and efficient information to those communities that they serve quite often has really been an area that counties have seen massive work with and have really helped with some of these transitions to with previous expansions. So counties at a local level are having partnerships with CBOs, making sure we have the same talking points, making sure communities know exactly what the eligibility criteria is. We've seen in other expansions where there's individuals out there trying to be helpful, but may not be giving the right information. And so having those partnerships with counties that administer the program and CBOs has been a great help in previous expansions, and we look to be doing that with the upcoming phase as well.
Great, that's very helpful, and it's great to be building on that past experience. Anything to add, Dr. Pan?
Yeah. So first of all, I'm extremely excited about I call it the final rollout because we've, as you shown the timeline, we took care of the kids with the seniors. Now we're picking up the people in the middle. And actually, I'm really thrilled about the results that were presented in the study because as someone who's been in the legislature to implement the ACA rollout as well, as we know that just providing someone an insurance card, whether it's Medi-Cal or a private insurance card on covered California, is usually not enough, right? People who haven't been covered often aren't familiar with what to do with coverage. What does that mean, right? And so the fact that in your study results, you showed that people who are undocumented either were equivalent to people who were not undocumented or actually even accessed services at a higher rate is actually kind of a positive sign that the work that CBOs are doing, that the counties are doing, are getting through in terms of people knowing how to use their coverage. Now, this is comparison to the Medi-Cal population. We know that there's improvements we continue to make to the Medi-Cal program to reach out. So be interesting to see how that compares to the general population. But I mean, I think these are really positive results, and I want to actually express my gratitude to all the county workers and the CBOs who've done this, because otherwise I was expecting to see a differential the other way, just because people, we could offer coverage, but people don't always understand what to do with that. So these are really exciting results. Firstly, I think that this part of the rollout theoretically should actually make things easier in the sense that now, instead of having to ask people their age, as long as they're undocumented, they meet the income limits, they can get enrolled. So there's one less thing that excludes them, right? And in fact, we know part of the reason we're covering the undocumented, certainly a very important reason is they need healthcare themselves. But the other reason is because oftentimes many households are mixed, they're blended. You have people who are citizens and qualify, for probably your children who are born here, people who aren't. And yet what we know is that when one person in the household can't get covered, the rest of the household tends not to get covered as well. And so by rolling out the coverage for people undocumented, in addition to, of course, they themselves getting the healthcare that they need, that also means that other people in their household, and that raises our overall coverage rate overall. So the fact that we can now go to a household and say, as long as you meet the income limits, it's not only documented, we have to say, well, and if you're undocumented at these ages, you can get it, but if you're not, like the parents can't, but the grandparents and the kids can't, right? So now we can just come out with a much more seamless message about that. And then the focus can then primarily be more on how do you use your Medi-Cal card, what services are available. We're not sitting there trying to figure out who's in and who's out. And so this is very exciting to me that by 2024, we should be able to accomplish that.
Fantastic. And a great segue to start thinking a little bit about what it does mean to gain coverage after having experienced barriers to care. So the coming expansion group includes middle-aged individuals in their 40s, and last year's expansion was to adults 50 and older. So Dr. Heinzman, as a provider in a safety net setting, what would be your priorities for new patients in the 40+ age range who had previously faced high barriers to care?
Yeah, thank you. I mean, it's a really key time in care. For multiple reasons. You probably most urgently as a provider, common chronic conditions tend to start to kind of rear their heads in patients' 30s and 40s, and so it's a very important time because those things have now occurred. They are kind of getting rolling in a negative way, and you have the opportunity to diagnose, to start treatment, to educate, to talk about, to hear about how folks are doing, and intervene on those chronic conditions at a really strategic time before they really start to develop complications. Similarly, when folks develop behavioral and mental health challenges, difficulties, that usually occurs earlier. And so by their 40s, they may be experiencing some significant complications. And obviously we heard a lot about that content in the report and wrote about that. And so the opportunity again to intervene really before complications really take hold and become difficult to manage. It's a very highly kind of critical time in people's healthcare. And be able to kind of, as Dr. Pan said, provide that kind of uniform care to families over time is really, really, really important. And there's also, you're at the onset of screening screening services for cancers once folks hit 50 or 45 and 50, and it just adds to the strategic nature of that time in people's lives for getting into care over time. So it's a really key time.
Great, thank you. Thanks for illuminating that, the importance of getting care in that age range. Anything to add, Dr. Pan?
Well, I as a pediatrician, I have to second what he said. I actually, prior to all of this, I actually helped found a not-for-profit in the Sacramento region to get children health care coverage who didn't qualify for Medi-Cal, or at that time, healthy families. So we rolled that into Medi-Cal later on. So essentially, there were a lot of undocumented kids. I'm glad to see that the state is now not only taking care of kids, but also their parents. Because one of the things we knew is even when we could provide healthcare coverage to the kids, the parents, I know I'm a pediatrician, so I don't, I see kids with parents, right? Or other guardians or other members of their family who brought them in. And you can, and even as you're trying to take care of the kids, you can see some of the health issues that are affecting the whole household, right? And it's heartbreaking that, you can't provide them some advice about that as well, or that they can't get coverage, or you can't refer them to, let's say, Dr. Heisman, who's a family physician who can take care of our other physicians, other healthcare providers who can take care of them. So the fact that we can say, look, everyone in your household can get coverage and then can get that care is so very important. And it is also mentioned, the screening happens at different ages, so we're not going to have a gap of people in between. But also, a lot of these things are, there's a generation cycle that happens, right? That happens as well. If we think about social terms of health and some generational impacts, right? So what happens when someone in the household has a behavioral health issue like depression, so that has an impact on the health and mental health of other people in the household. So the fact that you're going to have a gap there makes it much more challenging to treat the patient that you may be taking care of who has coverage because someone else in the household does not have coverage. But we have to realize, our health is not just ourselves, it's also the people around us. And so this step is going to help us address that.
And just to add, I think what we know about families and what we know about the state is that we have a population that is aging, and to have this middle group who not only assist their children, but they're also looked to assist their parents. It makes sense to have this group also covered because they will be, in a lot of cases and in a lot of families, those who are assisting the younger and the older generations in their homes.
That's a great point. Thank you. Thank you for adding that, Ms. Dury. Want to segue to something slightly different, but of course related to the coming expansion population. So we know that California is very linguistically diverse. In our project, we learned that it can be hard to recruit certain types of providers who are fully bilingual in Spanish, which of course Spanish is widely spoken in California. But what are the challenges for speakers of less widely spoken languages, especially those in the Asian American and Pacific Islander communities? Dr. Pan, can I ask you to start us off?
Yes, and this is a major issue for many communities, including the Asian American, Native Hawaiian, Pacific Islander community, but certainly for others as well. Even Spanish can sometimes be a challenge, but at least it's more widely spoken, and it's more likely we can get a interpreter who speaks Spanish, or someone in the clinic who speaks Spanish. But then when it comes to the other languages, that gets even more challenging. That becomes a really significant barrier to care, and particularly mental health, behavioral health care, right? Which is most of that is actually communications, right? What you hear from the patients and going back. So and so that's going to be particularly important that we reduce those barriers. When I was in the legislature, worked repeatedly on trying to improve that access. We still have work to do in that area. So I want to first of all applaud the fact that we are able to provide this Medi-Cal coverage, to undocumented of any age who meet the income requirements. But as I mentioned before, and we were comparing that to a Medi-Cal population, is that Medi-Cal itself, there's still things we need to do improve. And certainly one major one is the language barrier, because we know many people who not only undocumented, but including the people who are documented who qualify for Medi-Cal, speak many languages, and when they don't they can't go to a healthcare provider or that speaks that language, and they don't have interpreters for that. And by the way, as a clinic physician, I've run into that problem over and over again. It makes it really difficult to provide the quality of care people need, right? When you can't communicate, they can't communicate to you what their symptoms are. You can't communicate them what the treatment plan is. That becomes a major barrier to care. And actually, it's more expensive because we end up doing more tests and other types of things to cover the fact that we can't communicate easily or accurately with our patients. And so that becomes much more expensive, as well as providing poor quality care. So that's certainly an area that we have things we still need to do, including particularly language access is still a major issue that we still continue to tackle in the policy area.
And if I can, what I've heard from some counties is not only like we have language interpreters, but sometimes we haven't narrowed it down to the dialect. And so that's been something that's been raised quite often of, yeah, we have Spanish interpreters, but we need this particular dialect that may not have been as well known prior to seeing the individual come into our lobbies and request assistance. And of course, you know, AI and Google Translate is not working as well for some of these lesser known languages, but also culturally sensitive. Some things that do not translate very well. Some of the language we use don't translate to other languages very well, unless you're embedded in that culture and know how to effectively communicate the information to an individual. So really utilizing some of these community members to come on and join some of the ranking and the work that we're doing at the county level, and then of course as providers as well.
And I just want to really emphasize, there's a reason I use the word interpreter, not translator.
Yeah.
Talk about things like Google Translate and sometimes phone. It's not a literal translation of what someone says that's needed. It's an interpreter who can help navigate what the patient really means, and that includes the cultural context. So, for example, in the pediatric clinic when I was at UC Davis, we ended up using a sort of remote video, so not just the phone thing. Because the problem is a literal translation still does not convey the kind of information necessary to provide the quality care. So it is important that we actually have trained medical interpreters, and ideally, actually, the reason we use the remote video was because that person could then see the body language of the patient as well. That's part of the communications as well. It's not just simply the literal translation of the verbal word from the patient that's necessary to provide the quality care.
Absolutely.
The other thing that I think about in this, I mean, it's less the short-term policy issue, but it's just kind of an academic or a physician in an academic center, just thinking about making the representation of the workforce and across the board at all levels, physician, nurse, and medical interpretation as well. I mean, just making sure communities are represented, and how, because we know that our educational system in healthcare doesn't do a very good job of that, of representing communities very well. And it is a urgent and pressing and ongoing need to make sure we are training the healthcare workforce from every possible community. So it's really that issue is just should be on our, it probably isn't on our screens enough, and should be continually on our screen to address this problem going forward.
And I will comment as someone who's actually, one of my other roles is I am working with the American Medical Association on medical education issues. This is a very significant concern for the medical profession and medical associations, especially with the Supreme Court ruling banning affirmative action. How do we ensure we have a physician, not only physician, but total healthcare workforce that can actually meet the needs of our patients? The research that, for example, showed that you actually see a difference in mortality rate depending on the percentage of Black physicians among Black Americans, right, in that same community. That shows there's actually a direct link there in terms of the importance of diversity in the profession, in the healthcare community, and the impact that actually has on the health and even the mortality rates of particular populations.
Absolutely. And thanks both Dr. Hintzman and Dr. Pan for bringing us to talking about the workforce, because that, with a more diverse and linguistically well representing workforce, I think the need for translation or interpretation is much less. So let me step back a little bit and talk a little bit about what else is going on in Medi-Cal, which I think that probably is true. all over the country, but Medi-Cal eligibility redeterminations have restarted after a multi-year pause triggered by the public health emergency. And Ms. Dury, how are counties preparing for the January expansion in addition to the ongoing work of recertifying millions of Californians?
Well, obviously, there's been massive attention in this area, not only in the state, but across the country. And it makes complete sense because it does impact every individual on the program. But what we've seen throughout the unwinding process, and even before when we were preparing for it, was there are two major things that if you looked at any county readiness plan, they identified staff recruitment and retention and training. And so those are the two areas that counties have really become really structured and had a really robust structure that needed to happen for the unwinding. We had quite a few staff that had never done a redetermination for any cases prior to the unwinding starting. So coming up with some really structured methods of communicating new information to individuals, including weekly touch points with focused training, new requirements to show that what's changing, new reminders in our systems, and centralized locations to really look at some of the how-to videos that we've developed. And because of that work that needed to be done for the unwinding, we're able to quickly use these tools to use for any new changes. But I do think that it is important to note that although the unwinding is happening and although we weren't doing redeterminations for 3 years, we were always taking applications. We were always assisting individuals with questions. So some of those tasks continued throughout the full pandemic and are continuing now. We've also seen waivers that come through that make changes to Medi-Cal during this unwinding process. So what I will say is that though the unwinding is happening, it is a massive workload at the county level that we have things in place to prepare for any new changes that occur. And as you know, we're all Californians. This is not going to be the only change that happens or that's upcoming. We have the asset elimination coming up in January as well. And we're looking forward to other new changes that will happen in the upcoming years. And as the state legislature goes, we could have a new initiative coming out pretty soon that counties will have to be ready for, and using the work to prepare for the unwinding will really be beneficial. One of the areas I also want to talk about, and I don't think gets as much attention in this space, is our county systems and our state systems that are utilized to do the work to where we enter the information about each individual. Some of that work is already done for this expansion population. So if they're already a beneficiary, the county system will be able to automatically include them in this new expansion. So they wouldn't have to do anything additionally on their part. And so that's an area that we're really working to automate some of the work so that individuals and community members do not even have to come into an office or call an office, because they'll be automatically transitioned into this new expanded eligibility. Of course, barring if they have a redetermination coming up or any other case details or eligibility factors. But if they're known to the system, we'll be able to automatically include them in this new expansion.
That sounds like great news, and I'm sure that our audience members appreciate learning about that today. That's fantastic. I was also curious beyond counties, if Dr. Heinzman or Dr. Pan, if you have any comments about how dealing with both the redetermination, the new eligibility population might have implications for eligibility workers in community health centers.
Well, I would say, first of all, we know that a lot of people who lose their Medi-Cal or Medicaid, it's not because they actually don't qualify. It's because of some paperwork problem, right? Or documentation, or frankly, all of us are busy. And by the way, people who are poor are really busy. I think sometimes people forget that, right? They're chasing down lots of different things. And I appreciate that our county eligibility workers try to work hard to help them. At the same time, one of the things we need to do from a policy point of view is try to simplify the rules as much as possible, so there's easily understood by both the people who benefit, and help the eligibility workers. And oftentimes, in the sausage making process as a legislator, we spend a lot of time trying to figure out who deserves and who shouldn't deserve, and then we make it really complicated to figure out. And what that usually ends up doing is it ends up excluding people who actually we want to help. And so we should really be thinking about how do we simplify. I mean, there's someone's got argument we shouldn't have any of these rules altogether. Everyone should just get that's a whole other policy debate. But since at least at this point, especially with the federal government, it's clear that they want to serve a certain group of people, and there's certain rules. As much as we can simplify those at the state, make them as simple as possible for the counties to implement, and same for the counties, and that also makes it easier for us to communicate to people. That's when we're going to lose the fewest number of people, and the people who actually do qualify are most likely to get enrolled. So in the same way, actually, that we're now saying that we're not going to worry about what age you are, as long as as long as you meet the income limits, we're going to go ahead and provide you Medi-Cal now. We don't have to worry about age determination. That simplification, we should be thinking about other forms of simplification that allows people to get the help that they need. And also that, by the way, that also oftentimes saves us money. It reduces the overhead, it reduces the cost of trying to sort out things. And then, of course, it makes it less likely people drop off.
Yeah, I'd underscore that need for simplification. One of research project I was on several years ago, we included interviewing eligibility specialists at community health centers. And what was amazing that I learned through that process is how, they're almost part of the care team at a community health center, and having these highly, almost therapeutic conversations. And really, they knew other patients very well. They knew, they were into asking them very detailed questions, and could do so very, very sensitively and so there was a tremendous kind of care component to this administrative task, and often these conversations were relatively intensive, and they did an amazing job at it. And so when you think about a rapid increase in volume, it will be not just an administrative conversation, but the chances for all these relationships, which is good, but also does tap into what Dr. Penn is talking about, the need to simplify the administrative tasks as much as possible. In a sense, so it frees up those specialists to do that, but then have that educator role, have that connector role as people enter the set of services that a clinic has to offer. It kind of frees them up to do that even more when the administrative tasks are simplified, especially with the kind of imminent large increase or possible increase in volume. So just really I'd underscore that simplification point quite a bit.
Sounds like we're all on the same page. Thanks for sharing that experience. It's really interesting about the work that the enrollment assisters do. So I guess looking a little bit to the future, we're going to be enrolling a number of low-income undocumented immigrants, a group that had previously been left out of the ACA expansion, and then we have the different age groups of eligibility. So we've been sort of like slicing away at the remaining group of uninsured, undocumented residents. And as we approach 2024, I'm just wondering, Dr. Heinzman, how does gaining insurance change conversations about treatment options between providers and patients?
Yeah, it's pretty strategic. It's pretty considerable. Especially, community health centers do an amazing job. Obviously, they serve folks regardless of insurance. They provide this incredible spectrum of care. Maybe 80 to 90% of concerns can be addressed even in the existing system, but that 10% ends up being very strategic and important. And so, if you, in the course of your routine care, if the difference between not having coverage and getting, an ultrasound or for instance, is, something that's a minimal copay versus a $1,000 bill. That's huge, in potentially in a family's economics or an individual's economics. And so the ability to open up routine treatment options like lab or diagnostic imaging, certain medication options, availability of specialist referrals, even things like, going to see a physical therapist for a routine musculoskeletal complaint can make the difference between really getting something, covering a service that would really make something a few month kind of nagging thing go away versus something that turns into a longer, multi-year, potentially disabling thing. That difference can be huge just even with coverage. And so those kind of the ability to expand services past the walls of the community health center or primary care clinic, the opening up of those kind of very simple and routine options, even for primary care, that's all pretty significant, and and that this would allow those patients to access those options.
Yeah, I think as a pediatrician who actually also works in a community health center, community health centers have to take everyone. So if they don't have insurance, they pay on a sliding scale. But the problem is, okay, so now they see me and you said maybe we can take care of 80, 90%. What happens when they need a referral for a specialist, right? What if they need to have a test or an imaging or something like that, or they need a lab? Then, we're constrained. So because if they don't have coverage, then they've got to figure out how to scrape up the money for that. And even if we can work out a discount or something. So our ability to provide care when someone doesn't have coverage, it does get severely limited. Even, we can do what we can, but the healthcare is more than just what a individual physician or their team in a clinic can do alone.
Thank you both for those perspectives. It's certainly positive to be thinking about the changes that are on the way. So I just want to make a brief announcement. So we'll soon begin the audience question and answer. There's still time to submit your questions. So audience members, you can send them to the email address on the screen, PPIC event questions, all one word, @gmail.com. And please include your name and your organization. And returning for just one more, just a quick round of thoughts for the future. So one final question. So in a few words, what hopes do you have for undocumented health coverage and healthcare in the future? Mr. Reed.
Pie in the sky, and my biggest hope is to see more progress on a national scale. I think California has made amazing strides in this area, and of course there's always more that we can do, but I think COVID-19 really demonstrated that health impacts the entire community, so everyone needs to have coverage, and seeing more work to be done on the national and federal level would be amazing and really beneficial to everyone.
Great. Dr. Heinzman?
I think, I'm a primary care physician, and so I'm excited by this expansion just for the purposes of giving access to everybody in California to get access to primary care, and then even further what we discussed in the last question. And I'd probably just echo Mr. Reed's comments about hoping that trend is national. I mean, you see how when folks can get access to care, like we said before, the entire family continuously without interruption, how important and stabilizing that can be in the lives of families and communities. And my hope is that this trend just continues and would even extend to Oregon, which is where I practice, which is a similar policy kind of a state. But yeah, that national progress off of this is probably my biggest hope for the future too.
Okay.
Yeah, also to kind of add on to what Duri already said is that there's a few things certainly within the state of California and we need sort of federal cooperation. So for example, we should try to provide more continuous coverage. So I know we have to do redeterminations every year. Hopefully in recessions, we don't back that down to every quarter like we used to try to save the state money, but also extend it, right? And I know we've worked on some of those policies, like for kids, they should, once they get enrolled, they should be able to stay on for like 5 years, or if you're pregnant, that you're on not just through your delivery, but so we through at least a significant postpartum period, or other types of extensions, so that we can do fewer renewals. And then the other part actually is, we have a very successful exchange in California, Covered California. Unfortunately, it's not as accessible to people, not accessible to people who are undocumented, and so we can make that accessible. So again, as someone who's undocumented is economically going up the ladder and is more successful, they should not be losing their healthcare coverage because they're no longer qualified for Medi-Cal. So we should think about opening up those things as well and figure out how to make that happen.
Excellent points. Thank you. Well, let's turn now to some questions from the audience. So first off, we have a question from Ann Sunderland from the California Healthcare Foundation. And Anne asks, what are some specific policy solutions to increase access to medical interpreters? So are there training programs for medical interpreters that the state can subsidize? And additionally, can telehealth expand access to a broader pool of interpreters through video appointments? Kind of similar to what Dr. Pan was describing previously.
Well, maybe I'll jump on this first.
Sure.
Issue I've been working on. Frankly, we need to be sure that there are interpreters available at every site that's providing Medi-Cal, providing care to Medi-Cal patients. That is available at point of service. So, for example, I know most of Medi-Cal is delivered through Medi-Cal health plans, and I've had the experience where people have to actually schedule their interpreter in advance, and the patient has to schedule that. That doesn't seem to make sense, especially since the patient themselves, since they don't primarily speak English, oftentimes then is trying to interface with someone to try to schedule someone to interpret for their visit. We need to simplify all of that, and of course the burden of the cost of that shouldn't be borne solely by the clinic or the person providing the care, right? So we shouldn't be penalized for taking care of someone who needs interpreting. So we need to work that out. We also need to have again, trained pools. Telehealth or teleinterpreting certainly is something that can work, so that you don't have to have a collection of interpreters on site, but they need to be accessible, especially now with IT and so forth. We should be able to have a variety of interpreters available. And I think I already commented that it's ideally it's video with audio, not just a telephone little translation. So it should be actual interpreters.
Yeah, I think I echo those comments. And I do think, even though I do think a short-term aid is telehealth medicine. I'll confess some perplexity. We have video interpreters in the clinic that I work. We'll have face-to-face their interpreters and also video interpreters as well. And the technology never seems to work right. But we can. But when I'm on a Zoom, it works well. And so, like, what is it? Have we not? I mean, that for some reason I don't think the system necessarily has invested in making in understanding the key role of that, and to make sure that is high quality all the time, because we're in a day and age where we can have pretty high quality video interactions, and that should extend into this arena without exception, and that's with a lot of people trying very hard, right? That's not an individual's fault, but to make sure those technologies are really of high quality and available as easy as all these other video interactions are, I think is a short-term approach to that can be helpful.
Great point. Thank you. Going to another question. This question comes to us from Sacramento. And the audience member asks, what are the health insurance options for individuals who are undocumented but remain above the Medi-Cal income eligibility threshold? I think, Dr. Pan, you were starting to talk about this a little bit.
Yeah, I mean, well, let's put it this way. I mean, people can certainly try to buy insurance, but the problem is, especially if you're trying to buy on the individual market, that's why we created Covered California, to actually stabilize the individual market. And we do have laws. I was proud to author the state law that basically banned selling products that would discriminate by pre-existing condition, and many of those other protections as well. But I think, unfortunately, if you're undocumented, and some of that has to do is you can't get the tax credits and so forth, that you're excluded from the marketplace. And we need to think about how we can allow people to benefit from that Covered California marketplace, because it's more than just simply the federal tax credits and so forth. It's the active purchasing, it's the other things that Covered California does to try to keep the rates lower, and to maintain a certain level of quality. So I think from a policy point of view, we need to look at what kind of insurance options are available, and how do we ensure that people who are using those options can get the best best value for their money. But and we might want to consider whether there's opportunities for other forms of, if we can get federal credits. Ideally, that would be great. that there's other ways that we can help subsidize the cost for, if you're just over Medi-Cal, you're not making a lot of money. In fact, I should point out, a lot of people working actually are on Medi-Cal. So I want to just be sure we dispense that myth that people on Medi-Cal are not working. It just means they're lower income. Many of them are working 1, 2, even sometimes more jobs. And then people are just above are still working all those jobs. And unfortunately, now things get a lot more expensive. And so we should think about how we can help them out.
Great, thank you. I'm going to move to another question. This one comes from San Francisco, and the question is, are there any concerns about safety net providers such as community health centers and public hospitals facing financial issues post-pandemic?
I'll take a stab at least the community health center standpoint. I mean, I think I'm not sure if they're not new financial challenges post-pandemic. They're always there. I mean, I think it's, well, this is honestly, and it's an opportunity to comment on what the expansion actually does for community health centers, because community health centers receive cost-based reimbursement. So basically, an increased level of reimbursement for any Medicaid or Medi-Cal patient. And so when you change that ratio as far as the roster on a panel, you actually potentially offer the community health center more reimbursement for the services they're providing. And so this expansion will continue to, I think, bolster some of the financial stability of community health centers. Now, that's me on the provider end. I'm not in the financial workings of the community health centers, but as I understand it, there's a persistent kind of financial risk that those community health centers take on in serving their communities, anybody in their communities, and this expansion can only help actually.
I think in terms of the question relating to the impact on safety net providers, I mean, clearly COVID had a tremendous impact on the overall healthcare system, and that includes safety net providers, right? You suddenly saw a drop in visits because people were afraid to go to offices and clinics and so forth. And then also people had deferred care because of COVID. And then now it's sort of swinging the other way, right? Because now people are coming in to get care that might have been deferred or other reasons. And so I think the other part we also need to talk about is that healthcare professionals, nurses, doctors, other people, there's a lot of PTSD, post-traumatic stress that's happened post-COVID. We're seeing shortages in many health professionals because people are leaving the profession. Those shortages are because, again, people leaving. So it's not, I want to emphasize, not so much a pipeline issue, obviously, and so people often talk about pipeline solutions. We need to talk more about retention and really looking at the workload that various healthcare professionals are having to bear, because even as people are leaving, that means more work gets loaded onto people who are remaining, and then they start thinking about leaving. So those are some issues that certainly affect safety net providers and the overall healthcare system that we need to figure out. And then I just have to also mention, COVID. One of the things that we have to think about is long COVID, right? And so COVID can cause long-term issues for a lot of people. We're still trying to figure that out, but that's an additional, well, burden's probably not the right word, but additional demand for healthcare services as well, in addition to the mental health stressors that not just healthcare professionals, but everyone face, that also people we're trying to meet. And so we need to be sure we're able to meet those needs.
Great. I'm going to take just a moment to remind the audience that they can still submit questions to our panel. The email address is ppiceventquestions, all one word, @gmail.com. Please include your name and organization. I want to move to a question now that comes to us from LA. And the audience member asks, how do federal policies such as the public charge rule reduce program enrollment and access? I'm going to put this to Ms. Dury.
Well, I think part of the conversation is education. So when we're talking about Medi-Cal and some of the expansions that California is doing, we're talking about state funds, like some of our state funds, and how the impact to the public charge rules are different for this population for Medi-Cal expansion. But we also understand that that's a very nuanced answer. And so it does have a really big impact on how individuals in the community see it. And so really utilizing education tools to say, hey, this is something that we're doing as a state in order to make sure that you have the coverage that you need, and utilizing those trusted messengers to do it. But we know that regardless of some of the conversations, because that has been an item, in 2020, we talked about it a lot, the chilling effect of just having that public charge be out there, that it does require some additional work with a lot of community members and community partners to identify that we want you to come in and we want to help you. And the state is doing a lot of work in order to not have to rely so heavily on what the federal government is doing in their policies.
I would make a couple of very key points. First of all, as Doree mentioned, it's that our Medi-Cal expansion for undocumented state funds, so that would not fall under the public charge because it's not federal. The public charge is a federal regulation. Second of all, that regulation was not implemented because frankly President Trump was not reelected, and that was a policy of his administration. So I will just say this is a nonpartisan statement. Elections matter. Elections matter to policy. And so I think, as we're talking about this very important policy work that we did here in California to expand, that's because that's what the people of California did. They voted for people who wanted to develop and implement this policy. And so when it comes to public charge, people need to recognize that's a policy decision by an administration to do this, and oftentimes based on false impressions that are given out to the public. And that's where education is really important. There's education that needs to be given to people who are on the field, who in terms of what public charge really would mean to them. And again, unfortunately, it's very nuanced, and not only it's nuanced, it's oftentimes changing depending on the proposal. So I actually held a public forum to talk about public charge, to educate people in the field, and it was difficult because we didn't know we didn't have a final version, right? So, and there were lawsuits and stuff going on. So exactly what we could tell people and be sure they got accurate information. At the same time, it's also important to realize that these are policy decisions, and that if we don't want to have a public charge rule, it's important that we educate the general public about who is it we're talking about, right? What are truly their circumstances? And then people hopefully will make take that information and make that and make the kind of decisions about what kind of policies they really want, and who are they voting for. They'll implement policies that would make the most sense for their own community.
Absolutely. We have time for just a quick final question from Wendy Ayala from Los Angeles. So Wendy asks, what are mental health agencies' plan of action when it comes to providing more mental health care? And if you can't speak to mental health agencies, perhaps you could speak to other safety net providers, but Wendy specifies such as therapy, counseling, support groups, etc. Dr. Heinzman or Dr. Pan?
I mean, I would say one of the efforts in the last 10 years really has been to do what we call, behavioral health integration into primary care, is to co-locate mental and behavioral health and primary care services for everyone, generally across the board, just because then it's a much more of a seamless transition because often those conditions arise or are first kind of talked about in primary care. Then there are services right there, in the same building, across the hall, with a colleague, whatever. And so that is I think probably is still the future as well, is as much as possible pairing those services because people utilize them more when they're together. And so that's I think it's one of the big thrusts that I think we're seeing in Oregon, seeing in California for certain, even in this report, and then we'll be seeing even more of that.
And I would just say, again, first of all, second to that, we need to better integrate. We should not be trying to create this artificial divide between physical health and mental health, right? And certainly in primary care, we should be paying primary care sites to provide the basic mental health care. There's not enough mental health providers. The state of California is investing into building the mental health workforce, behavioral health workforce. We have a $4 billion youth mental health initiative. There's other types of things the legislature has been working on as well. But those will take time. Those will take time to implement. But at the same time, we need to actually try to create a more seamless system as well and reduce the barriers to people being able to access basic mental health services.
Excellent. Thank you. Well, this has been a wonderful conversation, but we've reached the end of our program today. I would like to thank Shalini Mustala for her presentation earlier and our panelists for this engaging conversation. Thank you also to our funder for supporting today's program and to all of you for joining us online. If you pre-registered for this event, you will receive a survey. We would appreciate your taking a minute to respond and let us know how we did. Thank you and have a good afternoon.